This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to our first Q&A episode of It's Not In Your Head. Thank you to those of you that submitted questions to us. Today, we're going to cover the first few.
First few. So here we go. All right, Jazz, off to the bat. So how do you answer common things from others, such as you're too young, it's not that bad, just walk, just lose some weight, go for it. What do you do?
Actually, this makes me think of how every time I leave, for example, a handicap spot, and I, as my 35-year-old, relatively normal looking self, leave the car, I'm expecting and almost waiting for someone to give me shit. And I have a spinal cord stimulator. So my go-to in my head has always been, I'll just pull up the back of my shirt and be like, listen, dude, I have a battery implanted in my body. Trust me, there's something pretty bad going on. But if you don't have something like that, it's actually really just a phrase that Dan and I have talked about often that comes to mind, which is just want to swap. Just because you can't see something and you haven't experienced something doesn't mean it isn't there. And one thing that has always irked me a little bit is this invisible illness term, which we even in the patient community use often. But it's bothered me because a lot of disabilities are invisible and a lot of illnesses are. And for whatever reason, we look at pain in particular as it should be this obvious, clear, you have a mobility aid, you have a GIMP, you walk with a limp, you're bent over, you're over 80. And that's just not true because there's tons of diseases. Cancer, if you're not going through obvious treatments that are very severe and equally as invisible. And so I think bringing that to light in kind of a simple, straightforward way along the lines of, look, illness does not discriminate. And just because I'm not old doesn't mean I can't have things wrong with me that you can't see. And because of a limited personal experience, you may not be able to sort of picture or understand. And so That's the first piece of things.
I think that it's got to come with a certain delivery as well. So what you want to do is someone effectively accuses you that, it can't be that bad or it's in your head or whatever. And you have to go, want to swap.
That's it.
No, you have to go, want to swap and silence. And so you got to just look at them and give them that time to step into your shoes, give them that uncomfortable silence where you're waiting for an answer.
Right.
And at which point in time, they'll
probably say no, actually.
They'll probably either say no or they'll tell you where to go or whatever. But nonetheless, it forces the doubter into your shoes. And it's a very powerful technique. I think I've told this story before. I got that technique off a patient who is a younger guy who had horrendous pain and was really struggling. And whether I pissed him off or whatever it was, he said to me, want to swap. And I thought, and it did exactly that. It shifted me into his shoes and made me think. And I was like, no way, dude. I'm good over here.
Yeah. Yeah.
So want to swap.
We'll make some t-shirts out of that. Yeah.
All right. Next one. Okay. Quick ways to communicate what's wrong when someone asks without going into detail. So what's the elevator pitch of what's wrong with me when you're just not giving them want to swap? Piss off.
Right. Well, this actually took me quite some time to get better at earlier on when I was first diagnosed and was living with complex regional pain syndrome, because a lot of people had asked me what's wrong with me because I had a cane, crutches, wheelchair, etc. And it was assumed that it was like a sports injury. So people weren't being rude, but I look athletic. So they kind of were almost trying to be nice. Like, what's wrong with you? But the answer to that is actually super complicated and personal and painful, and sometimes can even feel like an invasion of privacy. So for me, it kind of just boiled down to, and actually what I would on purpose do is use words that they, as a normal person, could kind of understand and maybe relate to, like, it's this rare, weird, hard to understand pain syndrome that's really hard to treat and makes it really difficult to bear weight for me in my leg, right? Or use a part of my body if it's your upper extremity, maybe. And that's it. You don't have to, even that can be too much detail depending on what you feel comfortable with sharing. But the other side of that too is that you don't owe an explanation to people when they ask you. It's your right to not have to share stuff. The upside of sharing it, in my opinion, is it can help increase understanding and empathy. And sometimes people are less dickish when they have a few experiences of like, oh, again, just because someone looks normal or it looks like it's not some traumatic, severe situation, it might be. And maybe I should not ask, or maybe I should be more cautious, or it just makes them kinder because they now have an example of somebody who's like that. And if you're unwilling to share, which again is totally fine, it's just a missed opportunity for that person to step inside your shoes, kind of like we talked about in the last question.
Yeah. I think if you want to just shrink it down, let's say you have a complicated condition such as a spondyloarthritis or psoriatic arthritis, or just cut it down to, I've got arthritis, like
right.
End of story. Like,
yeah.
Or if you've had multiple back operations, you can sit there and go, my back's stuffed. Yeah. And everyone goes, I get that. Yeah. My back's been like that before. And you can just shrink it down to those simple terms that people can actually associate with. So everybody knows somebody with arthritis. Everybody knows somebody who's had back pain. 80% of the world's had back pain. And, and if you add into it, hey, I've had back pain. It's been around for 20 years. It doesn't go away. I just cope with it. Today's a bad day.
What can they relate to?
Hey, it's my back. I'm having a bad day. Thanks for asking. Done.
Appreciate the inquiry. Yeah. End of story.
But that's sort of, you have to have that sort of strategy in your head to be able to explain stuff to someone. Yeah. And then at some point in time, if you feel comfortable enough with someone, sure, like give them the whole spiel. But I think things like that you've got in your back pocket, ready to go,
it helps de-escalate the situation so that you don't get triggered too, right? It's like you already know what to go to. It's no big deal. It's this, and keep it moving.
Yes. I love those strategies.
Perfect. All right. Next question.
All right. This is like a Juz expertise question. So how do you create boundaries and recognize your own capacity?
Yeah, this is also an advertisement for other episodes type of question in a way, right? So this is why we dove into pacing, energy management, essentially. We'll have an episode out on travel with chronic pain. And the reason those topics are important is because they're all about creating boundaries, recognizing capacity, and some of the challenges in that. And some of the important pieces are being brave and honest in how you communicate, your limitations, and not being scared or feeling shame too, and also surrounding yourself with people who even if they don't from a personal experience understand, they understand as much as they can because they care for you and they have your back. And from a recognizing capacity perspective, this one's all about sort of seeing trends and not signs like after the fact, once the train has left the station and you're halfway through our flare management episode, once you've fallen in the hole, right, in your diet and your support and your stress and these other pieces have gotten out of control. So I talk to my patients all the time about sort of looking at the surrounding variables when it comes to capacity and assess them. Like, what's your status from a hydration perspective, from a nutrition perspective, from a recovery perspective, from a connected to other people or grief perspective, right? Whatever some of those amplifiers might be. When it comes to capacity, it's usually recovery and fueling that are major ones. And if those are off prior, make decisions accordingly so that you don't do stuff that's going to cause you to bubble over because, I didn't even think about how crappy I slept or how little I ate, and I didn't have the capacity that I wish I had or would normally have.
So I see this, it's kind of written in a technical fashion, but I bet you this came from one of your clinician friends. My take on it is it's half glass full versus half glass empty.
Yeah. Okay.
And so when you look at boundaries, you're looking at, okay, that's a half glass full approach. I'm going to be able to go, I'm going to do this and I'm going to take it to this edge or this level. Boundary versus I can't do this.
Right. Yeah.
I can't do X, Y, and Z. And the other thing is recognizing capacity is the same. I can't do this versus I can do this. And
Yeah.
I had this exact conversation with a patient the other day who was like, annoyed that she couldn't get back to, I think she was struggling with getting to playing 18 holes of golf, right? And so previously not able to play golf at all. But
Right.
now we've got her back at playing 9 holes of golf, and as opposed to, we can't do it. I can't play any golf, and
Right.
so we've taken her through that process, and so it becomes a reframing of the situation
Love that.
rather than a I can't do this, I can't do this, I can't do this, and it just needs to be, hey, I recognize my capacity. I can play 9 holes of golf. I
Yeah.
couldn't play 9 holes of golf that long ago. And it's also in part of that is like and at the moment she's using a cart, which annoys her because she can't walk.
Right. Right. But
But she's just out with her friends. They have tea and cake afterwards. She's hitting
it's
the
like
golf ball.
it's like the golf version of bracing using a cart. It's like just do what you
Yeah, no,
need
but
to be
golf's the
able to
best.
do the activity, right? Like, and it provides all these upsides. Yeah.
So this is not a question, but I'm going to throw in how do you return to playing golf? This is a
Side
side
quest
quest. So
question.
side quest. So I love golf as a game. Now I don't play it at the moment because I've still got young kids and taking 4 hours on Saturday.
Yeah, I was
My
going to say from
wife
a
is
safety perspective, what you went
yeah
with boxing instead? What do you mean?
yeah. So boxing instead. So anyway, so golf's a beautiful game to be able to break down. So what you can do with golf is, number one, you think about the number of strokes you've got to take and you think about how far you've got to be able to walk. Okay. So
Yeah.
18 holes is just over six kilometers. So that if you're walking during the week, you can gradually build your walking up to that 6K mark. There's 18 holes that you can do. As we just described, you can take a cart,
Right.
perfect. And the other thing that is that you get on and off, someone else drives, you drive one hole, you walk the
Yeah.
next, et cetera, et
Positional
cetera.
challenges. Yeah.
The other thing with golf as well is that you just got to be willing to walk off. You come back, you're close to the clubhouse again, whatever is hurting, just go, I'm done. I'm going
Right.
to the
Call
19th
it.
hole, time for a beer, cup of tea, cup of coffee, whatever, and just call it. It's okay.
Right.
Like, awesome. The other thing you can do with golf is you can break it down. So if you actually think about how many strokes you actually make, you don't actually make that many strokes. So let's say you're going to go around in round numbers, you're mediocre, 100. Okay. So out of that, if you're playing 18 holes, you've only got 18 drives. You're going to have maybe 2 long irons, 1 short iron, and a couple of putts. And so you can then you go, okay, well, I only have to be able to hit 18, even if you're in 18 tee shots, 18 long irons, 18 to say 20, 25 short irons, and some putting. Now, if you then take that to the golf range, you you just have to hit a couple of balls. You don't have to hit tons and tons of balls. And if you are doing 9 holes, you can halve all that sort of
Right.
stuff. So you can go to the golf range and leave Bertha in the bag. Just get out your long irons. There you go. Hit
Break
18
it
long
down.
irons.
Yeah.
Break it down. There you go. And then like 18 long irons, 9 short irons, and some putting. That's
Yeah.
a round of golf, and
Yeah.
you can do that within an environment where you don't have to walk.
You didn't
You can
overdo
use your
it to
short
do it.
clubs,
Right.
and so you've broken it down into small components, and you get back to golf. So
Yeah.
I I love it when people say, "Hey, I can't play golf tomorrow. I want to get back." I'm like, perfect. This is easy.
Yeah. Well, it's a
So
perfect example too of you have a goal and then how do you break down that goal so that
yeah,
you can feel that you are doing something and you are improving without pushing yourself way over. And another
yeah,
really quick thing to think about, and this could be its own full episode even, but just from a what's called a pain menu is having a list sort of whether you're red, yellow, or green. Green's feeling good, yellow's red's real bad. What type of activities can you do or can you typically do in those different groupings? And whether you look at it from a pain number perspective of 0 to 4, 5 to 7, 8 plus, whether that's for you or your partner, it helps break down the barrier of, oh, I have to re-explain this every time, or go or think about it every time, or communicate it every time. And you kind of just know, and you have like a smorgasbord of stuff, and it's already kind of pre-established rather than starting from square one. And that also helps, right? Communicate and create those boundaries and be more aware of, given my capacity, what types of stuff can I do?
Nice. So the question was quick ways to communicate what's wrong. So I saw recently a wristband. So a wristband that on one side was green, on the other side was red. And so,
Yeah.
instead of being able to communicate to like your family, your friends, you flip it.
That's great. Put on the
And
band.
so you go green,
Yeah.
I'm good.
It's a non-verbal menu.
Yeah.
My God, it's sick.
Red,
Yeah.
like flick it onto the other
Right.
side, red, I'm not so flash. And it just automatically, because I think as you just said, you know what, a lot of people look not unwell, and
Right.
it's invisible, and so on the inside everything might be red, but on the outside it looks green. And that sort of strategy, I'll find what the company name was. It's pretty cool. I like them. Pretty
like
simple way of just communicating, hey, I'm no good at the moment.
Right.
And even if there's probably a bazillion other strategies that you can utilize, like particularly with family and friends, where you can say, hey, if I'm wearing blue today,
right, just know.
No. And so you sort of create those little signals for everybody. But yeah, red, green wristband, I'll find out who they were and we'll chuck it on the website.
Do a little product placement. I'll ask you this one, Dan. Well,
yeah.
Technically, it's for the doc. So what do you think, and again, this is another one we've kind of covered in episodes, but what do you think doctors could do better to support chronic pain patients? Because this way we can boil it down to a great, concise answer.
Okay, so this is interesting just trying to work through, because like this and the answer to this question is like, oh my God, there's so much we could do. Yeah. Okay, well, why don't you just start a podcast called It's Not in Your Head? So, okay, so there's sort of two components. There's two main things that I think that we can talk through here. So number one is a technique called strategic empathy. And we'll go through that in a little bit more detail and what I think around that. And the second piece, which is the ability to say, I don't know, but we discussed a little bit of this in the episode on how to communicate. So strategic empathy. So, okay, let's take it a step. When I'm seeing somebody, right, I'm trying to solve a problem and I am in my left brain trying to work that out. Okay, so
heavily left brain.
So let's put that into a context. So I remember, like when I was like a baby doctor, I worked at a place called the Alfred Hospital in Melbourne. There's 4 big hospitals in Melbourne, and the Alfred is the major trauma center. They've all kind of got their own trauma units, but like if you really like break yourself into lots of pieces,
this is where the worst stuff goes.
This is where it all goes. Okay. And so I remember like it's sitting there, and there's 2 components that really triggered this thought process. Was seeing like patients will come in and all these highly skilled emergency physicians just like roll in, all these nurses roll in, and they are then focusing on saving this patient's life. And the stuff that they are doing is amazing, but they're working through and they're thinking hard. They might not look like they're thinking hard, but they're acting fast, they're thinking hard. And to do that, if you then step into the tragedy of this for the patient.
Right. Oh my God, I feel so awful for this person.
If you step into the tragedy of this for the family, then it gets harder to think clearly and to act fast.
Right.
And so
more emotions makes it harder to think. We've all, I think, experienced that, right? On less intense example. Right.
And so that's where you start to get this piece where it's very hard to step into your emotional side while you're trying to problem solve and act quickly. So if you take that from the less urgent environment and you come into a chronic pain consult or any sort of consult where you're dealing with effectively anything, and doctors are running through multiple things, They're trying to check out. Firstly, they're trying to show that you're not going to die. There's nothing that's gonna
Right.
harm you significantly. And then we're trying to work out what's wrong. Okay.
Right.
I am thinking hard. If in the middle of that, the patient then tells me, this has destroyed my life. I can't do this. My wife's left me. And I find it really hard to then step out, empathize, and then step back into, now I've got to like get back to
Right.
solving this. And I think that what I do, and I've done it too regularly, and what a lot of doctors do, is they just don't step into the empathy piece. Like, it's too
Right.
hard to stick out of thinking and back into it being like a human being, and then back into
Right.
problem
Which is where
solver.
you get patient feels like doctor doesn't care. The
He
doctor
didn't
doesn't
listen
not
to
care.
me,
Right.
doesn't
Yeah.
care, da
Yeah.
da da. Okay,
Right.
so the technique for the doctor, and this is what I use, where I'm stay in my problem solving, but I then try to connect reasonably or acknowledge the patient's distress, and then
Right.
step back into problem solving. And so
Connect just enough.
enough,
Like,
acknowledge, step back into trying to sort it out. So the technique is referred to, like we refer to it, or I refer to it, as strategic empathy, where it starts with, that sounds, that must be, that,
right.
something along those lines. That sounds terrible, frustrating,
Right.
annoying. Pick a negative descriptor.
Right.
And then, which is acknowledged it for the patient, then saying, are you happy for us to continue to try and
Right.
find a solution? And so what you've then done is re-engage the patient to give you permission to keep going. And then you stepped in. And for me, it makes me not feel like a prick,
A jerk.
because I
That's
have,
what you
like a
mean.
jerk, because I haven't
Right.
like
Right.
stepped into it. But it also engages the patient. The patient
Right.
gives you permission to keep going, and away you go. And because I'm using it as a left brain technique, I stay in the left hand, my problem solving. Okay, my
Yeah.
problem here is I need to engage with this patient. I need to make them feel heard. Here's my technique, strategic empathy, boom, boom, boom,
Right.
continue problem solving.
Patient feels seen, validated. You even have some consent in there.
Yeah,
Are you okay if I continue?
yeah.
Right. And then everybody can get what
Everyone
they
moves
need.
on. So, and I think that's how we can better support patients with that, because that's really what the question is. The next piece in that is the ability to say, I don't know. But where does the inability to say, I don't know, come from? Okay, I can tell you this. It just comes from our training. Like, as medical students, you get shredded. And when you're a student a long, long way. You may have been a doctor in training. You were getting flogged continuously. And if you cannot say to a colleague, I don't know. Like,
Plus,
you just,
you don't feel, it doesn't feel good.
it doesn't
Like
feel
it does.
good. You
You feel
can't do
incompetent.
it. Yeah, you feel incompetent. You feel ignorant. You feel like,
You also feel
yeah,
like you're letting the patient down,
you
probably
feel
in a
like you're
way
letting
when,
the patient, like, there's a whole
but
stack behind
right.
that.
Which we, yeah.
However, the answer to that sense of frustration, annoyance, shame is not, you're crazy.
Right. This is where the
It's
harm
in your
trauma
head. Get
gets
out.
interjected. Yeah.
The answer is, I don't know, but what we're going to do is we're going to do this, this, and this to sort it out.
Right.
Or, I don't know, I'm going to refer you to see this person. They have that skill base. Or, I don't know, I'm just not the right person for this problem.
Right.
Let's talk to your GP about seeing somebody else.
Right.
Like, that is the piece, the power in saying, I don't know, but this is what we will do. And I think it acknowledges that most people are dealing with, complex problems. If you've seen 10 people, guess what? There is no one answer.
Right.
It's just, you've got a difficult problem. So, and I
This,
think that patients accept that. And I learned that from
well, and it's
a
preferred.
friend.
Yeah.
Yeah, yeah. But I learned that from a friend, Bruce Mitchell. He's, friend, mentor. And I'd sit in with him, and he did exactly that. He would say, I don't know. Actually, he
And
would say,
we talk
and he would
about like,
actually say, I don't know, mate. He'd say that to
right.
everybody,
Yeah.
females, males.
Well, this is why we did a whole episode on this.
Yeah.
Like literally.
So I think that they're the two things. I think doctors can better support patients with, number one, strategic empathy, and number two, being able to say, I don't know, but this is what we'll do. There you go.
Beautiful.
All right. I reckon that's good. Q&A, episode 1, wrap it up.
All right. So on this one, we covered how to answer common questions or almost accusations from others, like you're too young, it's not that bad, just walk. Went over some quick ways to communicate your situation, depending on how much detail you want to go into or not. We also covered how to express boundaries and also recognize your own capacity and some different specific examples around working your way up to activities that you love and taking back parts of your life, right, that pain has taken from you, whether that's time with your kids or golf. That all falls under sort of pacing and energy management. And then we pulled out a big chunk in particular on how doctors, because this is such an important topic, how doctors can better support chronic pain patients. And so take a listen to this and go into some of the past episodes for deeper dives into some of these topics, specifically on communicating and understanding your doctor's point of view, pacing and energy management, like we talked about. The sleep episodes would kind of fall under there. So that's what we got for you today. Thanks a lot for listening.
If you've got some other questions or you've got questions you'd like us to answer, whether being specific or general, throw them towards us at
the INEA Instagram. So that's where you can currently send them, because I put up question boxes, or you can email them to us as well at danandjuz@iniyh.com. And at some point we'll have something on the website where you can submit them there as well. I think that'll be helpful, but Instagram or email.
Beautiful.
Thanks. If you are a patient and you are struggling with the lifestyle aspects and the 7 buckets of sensitization that we've talked about, I do a group program called Basecamp. Go to my website, check out my link in bio if you're a patient who has struggled with implementing the habits that you would have to affect those 7 buckets so that you can bring down some of those drivers and the amplifiers on your pain and underlying conditions.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.